here at the Washington Post in D.C. I have been covering the healthcare law since Congress was debating it for Newsweek and Politico, and now cover it at the Washington Post. And there's been a lot that's happened over the past 3 or 4 years, and even more that'll probably be happening over the next 3 to 4 months. So what I'm going to talk about for a few moments here before I pass things over to two other really great panelists is a little bit of where we are right now and what you should be expecting to happen over the next few months. And what I wanted to start off with is where we are right now. Right now, we have one of the highest uninsured rates of developed nations, and what the Affordable Care Act focuses on doing is enrolling the uninsured and those in the individual market into new healthcare law programs. And if you're looking at this graph, we're essentially talking about the people in the purple and the red sections. And one thing I'll point out is that, while we talk about this as a very big law and it will be a wave of large policy changes, there are a lot of people who are going to see the Affordable Care Act come into effect and not see much of a change in their own situation. And the people I think about are this big yellow chunk of the chart. Everyone who's getting employer-sponsored insurance really isn't going to see an especially significant change when these new programs come into effect. So what we're really focusing on, and what I would urge you in your coverage to be focusing on, are what is changing for people who are uninsured, who don't have insurance right now, and people in the individual market who are purchasing their own policy. They're not receiving insurance through an employer or another public program. What the Affordable Care Act is aiming to do is increase the number of people with insurance, and this is one graphic that our team here at the Washington Post has put together that I found quite helpful. And there's essentially two places where you're going to see that increase in insurance coverage. You're going to see it in Medicaid, which is a state-based program that covers low-income and disabled individuals. And if you look at this chart right here, we're looking at an increase between 2014 and 2023 of 13 million people expected to join the Medicaid program. So that's one big way that the Affordable Care Act expands insurance. The other one is through something called health insurance exchanges, which I know will be a big focus of this webinar. And these are online marketplaces where, if all goes as the administration has planned, individuals will be able to type in the URL, compare insurance options, and ultimately purchase coverage. And the expectation, and these are all numbers from the Congressional Budget Office, which is an impartial budget scorekeeping office here in Washington, they expect that in 2014, 7 million people will receive health insurance through these online marketplaces. Some people will use paper applications, but the expectation is that most people will join through these new websites that will launch for open enrollment on October 1st. One thing to keep in mind as you think about the Affordable Care Act is you'll notice this amount of uninsured. Right now there's 57 million people who lack health insurance. While projections do show that number going down, we don't expect it to disappear completely. The Congressional Budget Office says that there will be 31 million people who do not have health insurance a decade after the Affordable Care Act is enacted. A good number of these people are undocumented workers who are not eligible for the health law program. There's an expectation that some people will not comply with the mandate to purchase insurance and instead pay a fine. And there are still others who will receive some exceptions, either due to the fact they can't afford health insurance or a religious objection or a number of other objections that have been allowed under the Affordable Care Act. So there will be a few people who, or not a few people, I'd say a significant number of people who will not have health insurance coverage even when this law is fully enacted. The big number for 2014, though, is 7 million, and that comes from the Congressional Budget Office. They project that 7 million Americans will enroll in private health insurance in 2014. And the White House believes that of those 7 million people, 2.7 million will need to be young adults between 18 and 35. Young adults are crucial to the Affordable Care Act's success, and the reason for this is that they tend to have relatively low medical bills. Someone who's 20 probably has much lower health care costs than their parents who are in their 50s. And in order to keep premiums down, the White House when I speak to officials there, they say you can't underestimate the importance of getting lots and lots of young, healthy people to sign up for health insurance. And young adults, they're an important demographic for the White House. They're also a challenge. They tend to have lower incomes. They tend to be more skeptical of purchasing health insurance. If they're healthier, they might see less of a need for these benefits. So they're a crucial audience for the White House, and they're expected to also be a skeptical audience as well. Right now, over the next few months, we're really leading up to October 1st. That's a key date I would circle on your calendar. October 1st is when those websites I mentioned, the health marketplaces or health insurance marketplaces or exchanges, open for business. Every American in every state, no matter where you live, if it's Texas or California, come October 1st, will, if things go as the administration plans, they will be able to go online and use an insurance marketplace. And right now is crunch time and getting those ready. If you look at some of these quotes, and these are just from my own reporting on the Affordable Care Act, one thing I hear from state officials is just, what Kevin Cunahan in Connecticut told me, I wish we had one more year. I wish there was more time, that this is an incredibly tight timeline that they're trying to build these marketplaces on. And a lot of the technical work has already been done, the actual computer programming to build these exchanges. Right now, the next 3 months are all about outreach. They're about letting people know that these new benefits are going to become available and how they're going to be able to access them. One conscious decision that the White House has made here in Washington is they're going to wait until later in the summer, until August or September, to really do their big outreach push. And the reason they've decided to do this is they don't want to sell people on a product that doesn't exist yet, that they want to wait until they can actually point to something on the shelves. One comparison I've had made to me is that if they start doing outreach right now on July 30th, it'd be a little bit like trying to ask people to vote in September. It's just not the time when they can do anything. It's a risky approach, and I know some people are worried that they're waiting too long. And I think that leads into the next section of this is some of the big challenges that the administration faces right now as they get started on their outreach push. But one is lack of awareness, and I think this is something that health law supporters are very worried about. Right now, 42% of Americans are not sure whether the health care law is standing. 12% think Congress has repealed it, 7% think it has been overturned by the Supreme Court, 23% just aren't really sure. So there's really a huge lack of awareness, and I know this worries Affordable Care Act supporters as they're going to be doing outreach that people just simply aren't aware, and if they don't know about the benefits, they are not going to sign up. Premiums are another big focus, and one thing I think that'll be a huge storyline going forward. There's a concern that if the premiums are too expensive, people simply won't decide to buy them. Right now, at least when I hear from the White House and Health and Human Services, they're pretty happy with how premiums are coming in. And you can see in this chart, they believe that premiums have come in slightly lower than the Congressional Budget Office has estimated. And you can see there's a real range from, an average of $280 in Oregon to a high of $440 in Vermont. I will note that these represent silver plans, which are essentially the second, are a type of plan you can buy on the exchange, not the most bargain one, but kind of a middle-of-the-road health insurance plan. And one other thing to keep in mind, whenever you're seeing premium data like this, all of this is before subsidies take effect. Millions of Americans are going to qualify for tax subsidies that if you're, for example, in California and you qualify for a tax subsidy, you might not pay $368 for this plan represented here. You might pay as little as $200 or $150 depending on your income. But $200, $150, those are still big premiums. And one of the big obstacles the White House faces is convincing people that this is a worthwhile, very significant purchase for them to make. The Medicaid expansion is a challenge that the White House never expected to have to deal with. Originally, as written, the Affordable Care Act expanded Medicaid to anyone who earns less than 133% of the federal poverty line. For an individual, that's just about $15,000. The Supreme Court ruled that that part of the law was an overreach by the federal government, that the federal government could not compel states to expand their Medicaid programs, which have ever since the program began, actually 48 years ago today when the Medicaid was signed into law. It's always been a state-federal partnership. And the Supreme Court said forcing states to expand to this level was unconstitutional. That means it's up to states to decide whether they want to expand Medicaid. And right now, according to the Kaiser Family Foundation, only 24 states have decided to move forward. That leaves a lot of people left out by the Medicaid expansion. And you can see that in this chart also from the Kaiser Family Foundation. All those people in orange, that's who they estimate the percent of people who would have been eligible for a Medicaid expansion if the Supreme Court had not changed this part of the law. The Kaiser Family Foundation estimates that 46% of those under this poverty line cutoff are not going to be eligible for the Medicaid expansion. And this creates a real challenge for the administration and its allies to explain to people, well, if you earn $20,000, you're eligible for a lot of tax subsidies. But if you're below 100, but below the poverty line, there's not much we can do to help you. And I have this quote from someone who's done a lot of healthcare polling that really gets at this. How do you explain this in a way that seems fair and reasonable, that higher income people get help, but you don't? Advocates on the ground are really struggling with that group. And one last challenge, but an important one nevertheless, is opposition. The Affordable Care Act remains, just as popular or unpopular, however you want to frame it, remains pretty much the same in the public's eyes since it passed on March 23rd, 2010. People haven't really budged in their views, and you've seen actually over the last few months a slight uptick in unfavorable opinions of the Affordable Care Act in Kaiser's polling. I would say we've seen some of those upticks before. I wouldn't read too much into it. I think what you can certainly say, though, is as the law is coming into effect, Americans remain just as divided as they've ever been about the Affordable Care Act. The White House says they know how to sell this law, and they say what they're going to do is focus on young adults. And the person you see in this picture is David Seamus, who is the Deputy Senior Advisor for Strategy and Communications at the White House. Before he had this position, he ran much of the polling operations for the Obama administration, and he has spent all his time obsessively studying young people, understanding where they live, what television stations they watch, who they'll trust when it comes to health insurance. And he has some experience on this. The Obama campaign in 2012 really focused on reaching young people. So the administration would argue that they know how to target this group of people who have really been their core demographic. So what you can expect to see really in all states is a huge focus on young people, figuring out where they are, who they listen to, and going to those places to try and make sure they enroll. There's an expectation that older people who have more healthcare problems, they'll probably seek out the law. They don't need as much urging from outreach campaigns. It's really these young people that are going to need a lot of help signing up. This is actually grew to 6 in the process of editing. I apologize for not editing the title, but here are 6 groups I would keep an eye on in your coverage going forward. The first is the White House. This is their largest legislative accomplishment during the Obama presidency, and there is going to be every effort made that they can to make this law work. And like I said, young people are going to be a focus, but you can expect everything from celebrity spokespeople. The White House just had a meeting last week with celebrities like Oprah and Amy Poehler and Cal Penn, who all want to promote the healthcare law, to the President and the First Lady both getting involved and very aggressively advocating for the Affordable Care Act. Enroll America is a new nonprofit that will be doing a lot of outreach in states that have not been active on the Affordable Care Act. And these are states, some of the 2 biggest ones are Texas and Florida, but you can expect to see them going to states that have declined to build their own Medicaid, or declined to build their own marketplace, and declined to expand their Medicaid programs. They will likely be going into those states and filling in for the state agencies. In the states that have built their own insurance marketplaces, you can expect those marketplaces to play a major, major role in this, that they will be out this summer doing advertising, going to community fairs, holding town hall meetings, that they're going to try and get people to sign up. Health and Human Services has a huge role in this as part of the Obama administration, and they're doing a lot of work with supporters of the Affordable Care Act. They have launched a website called healthcare.gov. Secretary Sebelius, who runs Health and Human Services, has said she's going to be touring the country in support of the Affordable Care Act. They'll be key to watch. Anti-Obamacare groups are still oppose this law, do not want to see it go into effect. You can expect them to be working on campaigns that range from the negative financial implications of Obamacare, which they believe is going to be too expensive, and also we are seeing some evidence of some campaigns to tell people maybe you don't want to enroll in this insurance. Maybe it'll be too expensive and you should just take the mandate, or you should just pay the fine for the mandate instead. And the last one I would mention are state health agencies. And this is especially true for Medicaid agencies in the 24 states that are expanding Medicaid. They will likely play a very significant role in getting people signed up for these new programs. As for what outreach will look like,
I think I just want to let you know we have about 1 minute left on your presentation.
Great. Well, I have 2 slides left, and I'll go through them.
Perfect.
Outreach will be like anything. I recently wrote a story looking at the different efforts people are doing. In Washington State, they're literally looking at advertising on porta potties at concerts because they believe that's a good way to reach young people. In Connecticut, they're going to give out sunscreen that's branded Get Covered and with their Exchange logo. And the picture you see here is from a recent television ad for Oregon's Exchange, Cover Oregon. So it's really a sprint to the finish right now. From today, there are 63 days left until October 1st. Each one counts, and I think there'll be a lot of great stories between now and then. Thanks, Michelle.
Thank you so much, Sarah. That was really helpful, and thank you for going through all this material so quickly. We'll have a chance to go back to all this again in our Q&A period. I also just wanted to remind everybody of 2 things. One, for our audience, that our hashtag for this event is ROH Obamacare. And then for Richard Figueroa, who will be speaking next, I'm hearing that Sarah's voice was fading in and out a little bit, so just maybe just make sure to speak loudly. Thank you so much, Sarah. We're going to turn now to Richard, and in a moment we should all see his screen. Okay, Richard, your screen is up.
And can you hear me?
Yes.
Great. So thanks for allowing me to be on this webinar. I'm Richard Figueroa. I'm a director here at the California Endowment and work primarily on implementing the Affordable Care Act, or Obamacare as we call it. I want to give you a little bit of a bird's eye view from California. Obviously, it was a very good presentation prior to this, kind of laying major groundwork. We are ground zero in some ways. For implementation of the Affordable Care Act, we have the largest number of the uninsured. We're the first state to pass an exchange bill post-passage of the ACA. Very large and diverse population requires a variety of approaches, and we have an aligned governor and legislature and public generally supportive of implementation. What are our markers of success in California? Obviously, the rate of uninsurance should begin to decline. We hope to have active oversight of rates by our regulators, which should positively impact our rate trends over time. We'll need a large number of assisters, possibly numbering 20,000 or more, to help people enroll. We hope to see an active use of preventive services, which is kind of underlies the promise of Obamacare. And the progress on the remaining uninsured, which means, at least in California, that a number of state and local dollars will hopefully be freed up because of Obamacare that can be used to apply to those that are left. A little bit about the sources of health insurance coverage. I guess the number of uninsured at any one time in California is about 5.2 million. At some point during the year, it's more between 7 and 8 million, so we have a very large task ahead of us. And then we've identified with a couple of the pie slices the size of the individual market and the small group market in California, which are the most affected by the subsidies and by the SHOP Act portion. When you look at sources of coverage, there's a very unequal distribution of the uninsured by ethnicity, which will be driving a lot of the efforts in California. If you look at the uninsured bar, you will see that they are disproportionately Latino, for example. And Latinos in California, Hispanic, as identified by the slide, represent about 38% of the population in California, but represent 61% of the uninsured. Again, you will see later that will be driving a number of our efforts. So while we needed the new health care law, I mentioned before, at some point during the year, we have between 7 and 8 million people that are uninsured. And once fully implemented, we think about 92% of Californians will still be uninsured, but there's still that 8% that are a significant amount that will still be uninsured, including the undocumented at the end of the day. And that's assuming we do a good job on outreach and enrollment. Another way to look at this is if you look at the 10 worst places for health coverage in the United States, we have 4 of the 10. Texas is a close second with 3. But again, it just is an example or exemplifies the work that we have to do in California. So starting with Covered California, which is the kind of the logo, the name of our health benefit exchange in California. Covered California believes they have to reach about 5.3 million Californians who are currently uninsured or purchase health insurance on their own. And so their marketing campaign is going to be geared toward about 5.5 million folks, half of whom qualify for subsidies and half of whom don't. There are also an additional 1.4 million Californians who will be newly eligible for Medi-Cal, which is the name of our Medicaid program in California. Looking at this kind of geographically, you can see that it's heavily weighted towards Southern California in terms of where the subsidy eligible population is. And about a third of those are in LA County alone. So again, very heavily Southern California. LA County represents a very, very large share, and the Medicaid distribution of those that are newly eligible kind of reflects the same geographic pattern. So looking specifically at outreach and enrollment, we've kind of divided into like 3 different ways of looking at it. One's in terms of obviously affordability, and you heard Sarah talk about that earlier, the need for effective outreach and marketing, and then of course smooth enrollment, so once you can activate them to or motivate them to try to enroll, that there's a smooth process for actually getting the coverage. This is a little bit about those that are eligible for premium assistance and the affordability for those individuals. Obviously, people that are insured right now are going to see a substantial reduction in coverage, or substantial reduction in premium costs if they're below 400% of the federal poverty level. The uninsured, even a larger savings, because they tend to be even lower income and will have the opportunity to see both reductions in premiums and their cost sharing. And then for the uninsured who are above 400%, less so because they aren't able to take advantage of the subsidies. So to do this, we have to have some very large-scale community mobilization efforts around key milestone events, earned and paid media. We have a large-scale community-based grants program, $43 million for Covered California, and $25 million for Medicaid, which is actually, we're putting up the state share, and we expect to be matched by federal dollars. Very, very broad exchange targeting. Obviously, there was a discussion earlier about the particular target markets, particularly young invincibles we're looking at, and then more targeted Medicaid groups with the community-based grants program around young persons of color, homeless, persons with limited English proficiency, and persons that are associated with the criminal justice system who may have never been eligible before. And then a very robust program for certified enrollment counselors through fees, which we'll talk a little bit more about. So again, getting a little more into the Covered California marketing initiatives, they're going to be spending $187 million over a 2-year period, starting now, and obviously going ramping up as we get closer to open enrollment and coverage dates, around community outreach, certified enrollment counselors, and traditional paid media campaigns. A visual representation of those dollars is on this next slide, very heavily focused on paid media and community mobilization, and I'm going to kind of go a little bit more into the community mobilization efforts, which are the direct outreach efforts. This may look like a lot of money, but it's not, because this is a big state. So looking at how consumers are going to enroll, we think about 60% are going to enroll online. The biggest chunk of that, actually the biggest chunk overall, is going to be through certified enrollment counselors, which are a much smaller amount on paper, only about 20%. Looking at certified enrollment counselors, it's kind of the largest single pathway that we expect. We know that we're going to have to deliver assistance through trusted and known channels to reach as many people as possible, and we think about 50 to 75% of applicants are going to be needing assistance to enroll. These counselors are going to be trained, certified, and registered with the exchange or Covered California to enroll people both in Covered California and Medicaid off a single application. So people are going to have one portal, and the certified enrollment counselors will be trained to enroll both of them, both target groups. There'll be $58 fee for both Covered California and Medicaid applications for successful enrollment. And right now, outreach grants are starting through Covered California, and then Medicaid in early winter to drive people to these certified enrollment counselors. So right now there's a big education and outreach effort going on to let people know kind of what's coming, and again to drive them to these certified enrollment counselors, given the large amount of people that we think are going to need assistance. Concurrent with this, we also are going to have very large customer service centers to help people with Covered California Enrollment and with additional referrals to Medicaid. So about 850 staff manning or peopling these customer service centers to assist people with a big flex workforce as enrollment ramps up. Some sample Covered California messages are going to be like in 3 general buckets, like who's eligible, given this is kind of a new thing, what type of insurance is going to be offered. Again, this is a new thing, but it is obviously quality, comprehensive, it's plans you know. And then what is the marketplace? What is Covered California? And how easy is it going to be to enroll? So these are some, I don't have the specific ad copy for you, but this is kind of the general kind of messaging that's going to be out there. On the Medicaid side, a little bit different. Obviously, that's at no cost in California. It's free, so you can have free, and you're going to kind of emphasize different things: free annual wellness checkups, affordability, obviously it's free, and then financial security. And basically, it's not your mom's Medicaid, because right now, as you know, Medicaid is primarily focused on families with children, and so obviously this is going to be a big expansion into those without dependent children. The role of the California Endowment, we're the largest healthcare foundation in the state. We see this as a huge opportunity for large-scale impact on community health. And so we're putting up $150 million of our own that our board is making available to complement the work of Covered California, mostly on the Medicaid side. Obviously, the federal government made available large-scale grants to state-based exchanges, but there wasn't any such funds available on the Medicaid side, and our own budget issues out here made it difficult for California governor and legislature to put up that money. So we're basically putting that up on behalf of people that are seeking enrollment in Medicaid. So we'll be putting up the dollars for the Medicaid certified enrollment counselors. We'll be doing large-scale customer assistance. And I want to talk a little bit about our Spanish and other language media and then small business outreach. We have a new campaign we're calling Asegúrate, which means get insured, in English, get covered. That's primarily going to be focused on California's Latino population that reflects the top messaging to drive interest regarding access to preventive care. Again, why the Latino population? Reflective of the earlier slide I showed about Latinos are 38% of the population, but 61% of the uninsured population. The Asegúrate Spanish language media partnership includes the California Endowment, Covered California, and the media outlets Univision, Telemundo, and La Opinión, which together reach almost the entire California Latino population. The president himself was out here about 4 or 5 weeks ago announcing this particular partnership. We know from it's a great fit because we know from our Latino research that doctors, news anchors, media personalities, promoters are the most trusted messengers. And then in terms of the methods of getting the communication out, Spanish language media, in-person assistance, phone assistance, the website are the preferred sources, but in that order, the Spanish language media being the first. So basically, this partnership will allow for surround sound by our Spanish media partners along a number of communication platforms, which I've listed here. Obviously, we're going beyond the Latino audience, and so here you have a number of other entities that we'll be using to reach particular audiences in California. Again, primarily focusing on the Medi-Cal population, since Covered California is going to be having surround sound among the exchange-eligible population. And this is just kind of an example of the English language media that we, the California Endowment, are sponsoring to kind of highlight what's coming. So again, this is kind of a snapshot of a very major undertaking by many partners in both public and private sector in California that we are undertaking to mobilize enrollment and make Obamacare a success in California. And here's just a couple helpful links about Covered California, the Asegúrate campaign, obviously the federal website that was mentioned earlier, and then a health law guide for business. We have partnered with a number of small business entities in the state on co-branding a place to just kind of just the facts for business. And then my contact information, and thank you very much.
Thank you, Richard. That was perfect. We're going to turn now to Peggy Gershman, a veteran journalist. She's going to really comment on some of the ideas shared by Sarah and Richard and offer us some story ideas.
Okay. Am I on? Hello?
You are.
Can you hear me?
And
okay.
Yes, but we don't see your PowerPoint yet, so you should click the little icon.
Show my screen.
And folks, I just want to mention. There we go. We're perfect. I just want to mention that if you click on the little question mark icon on your control panel, you can type a question for one of these three speakers or all of them, so that we can, as soon as Peggy's done, we can take some questions from folks.
Do you see the little doodah up there? How do I get rid of that?
Don't worry about it. No one else sees it.
Okay, it's not.
So,
okay, good. Thank you. Sorry. Hello, everybody. I'm Peggy Gershman from Kaiser Health News, and if you're not familiar with us, we do things for our own website, and we share a lot of material with media partners. Anyone can use our material for free, and we also sort of try to plan things in advance with news organizations, which include Washington Post and NPR and USA Today, among many others. And so we're in a position of trying to pitch people, other news organizations, as well as sort of deciding what we want to cover for ourselves. So I feel your pain often. And the first thing is I wanted to talk about what we call the law. And it seems to be about split, Obamacare, the Affordable Care Act, and the health law. I looked up some Google trending terms. And actually, right at the moment, more people are searching on Affordable Care Act than either Obamacare or health law. And no one calls it health reform anymore. So that's just an interesting thing. And we made the decision, as well as other news organizations, to be able to start calling it Obamacare instead of things like the health overhaul, which made no sense to people, but we had to call it that anyway. So I wanted to talk about how various ways that the health law implementation has been covered, or pieces of the law. And the first one I want to talk about is news. There's been tons of news, which has been great for all of us. An example of this is what happened a week or two ago when the New York Times published the rates for New Yorker, it was a big story at the time, and the New York Times and Bloomberg sort of played it sort of straight. There's other ways to write the headlines and write the stories that I wanted to just mention. So NBC sort of focused on what the president did, and Politico focused more on sort of the political aspects of who supports the law. All of them had the rate information in it, but they took a different tact. The Boston Globe took a completely different tact off the same news, and they looked at what's happening in Massachusetts alone, since newspapers now are very locally focused, and they said, look, let's take a look at what's going to happen to us with the new law, and they wrote a story about how it might push up costs. Marketplace, the nightly public radio program, sort of took a different tact, which we also did at Kaiser Health News, which was looking at other states in the country and seeing how New York was somewhat unique in how it approached this, because they take all comers now, so their rates are more likely to fall than other places. Wall Street Journal was looking ahead to how the president was going to, and his team were going to try to sell it, as Sarah talked about. And Med City News felt very comfortable talking about just California. That was a story that they sought out, but they can use the ACA in a headline and still get away with it. So it depends on who you're writing it for, what kind of terms you use, and how much you have to explain it. So all these people used one news event to make different stories. And this is the law that keeps on giving to journalists. We just love it because there's so many things going on with it. Sarah talked about October 1st. We have the individual mandate actually beginning January 1st and coverage beginning January 1st for many folks. These are all opportunities to cover it as a news event and to tell your editors, or if you're an editor, to get it on the front page or as a lead in the show. So we want to make sure that people know that this is a great way to sell your stories, no matter who you are, including if you're the editor of a website called Kaiser Health News. You think, okay, what dates do we have and what do we need to cover? March 31st is an interesting date because that's the end of the sign-up period, that if you don't have insurance, you won't have a penalty. And then the employer mandate begins January of 2015. That's the thing that got delayed. But recently I heard at one of Michelle's seminars, a National Restaurant Association guy saying all their people have to start planning now. Even with the slip in a year, they have a lot to do to satisfy this employer mandate. And they're very serious about trying to get their members to start looking at it. So there's lots of opportunities, even ahead of January of 2015, more than a year from now, more than a year and a half from now, to do some stories pegged to that date. Another sort of news thing that isn't as newsy as releasing insurance rates is events. And I wanted to show you these 3 examples of how events can matter. On the lower left, you see these are 3 ways that everybody covered these health fairs where people line up in the middle of the night to get free health care for the day. It's often dental stuff because that's expensive and hard to get. So bottom left is a local TV station in California, and they did a minute 45 standard package with lots of B-roll and a couple people there. Then above that is how NBC Nightly News did it, and they did it in an interesting way where they started in the studio and then they threw to the guy who was live, the reporter who was live in front of all these people, and then they just did a package that involved just one couple that was there, and they sort of told their story in a deep and interesting way for 2 minutes and 50 seconds, which was an interesting approach for the nightly news, and then they wrapped it up back in the studio. And the one on the upper right is a 24-minute documentary that has no narration, and it just takes you through a full day of one of these fairs with just supers over the video, and then you heard people talking about why they were there, and it was beautifully done by West Virginia Public Television. The one on the bottom right was based on another event, and they used that as a peg to talk about what was going on with recruiting people to sign up. And I wanted to say that even though 3 of these are broadcast, you could do that same thing in print form because, for example, the one in Berkeley County, West Virginia, you could do that almost as a timeline in a newspaper or on a website. So I thought that these were decent examples of a way to use just a simple event, which you could cover straight or in other ways. Then there's other ways to cover this stuff, explainers. We cannot do enough explainers for ourselves, our partners, our readers at all. First is data display. This is especially, of course, good online. These 2 charts came from the same story in the Texas Tribune. And if you see the one on the left, you could click on the different links and then the chart would move around based on what was going to happen. So you could see how many people were going to be at the baseline, which you don't see any gray in this at all. But if you click on that baseline thing, you see the gray grow, which is the baseline of 2013. And then you can see sort of the impact of Medicaid enrollment as it's expanded in some places. The one on the right, I think, is actually less successful because, at least on the way I read it, and I tried clicking on it on the website, the balloon hides some information. But this is the insurance market for Texas, and the balloon hides all the people who might be getting subsidies and a percentage of that. But it's a nice way, other than the fact that the balloon hides the thing, they're livening it up a little, the pie chart, and then you can still get information there. Another thing that's been wildly successful for us is FAQs, where we write a couple of paragraphs and think of really basic questions. This accountable care organization thing, ACOs, which when we wrote it a couple of years ago was unbelievably wonky. Nobody was talking about them except for people in the industry, and now this is one of our most searched things. It's in our top 10 stories, including like every day practically, because people still want to know. So we write a couple of graphs, sort of an overarching thing, sometimes pegged to news that might have just happened. Then we do very basic 4 or 5 questions. We move on from there. This can also be done on
5 minutes left. I just wanted to let you know.
I'm okay. No problem. Thank you. This can also be done on the air with hosts interviewing a reporter, really basic stuff. In the same way a host can interview a reporter, NPR does this regularly with Julie Rovner, their fabulous health policy correspondent, where they ask people to write in. They do a call out on the air and online via social media to send in questions, and then they sort through them and they try to find things that are typical or interesting, and then the host asks Julie to answer them on the air. And the people don't ask them, but the host asks for the people, and she's going to do this more and more as news ramps up. So it's another way, somebody will write in and say, I'm on Medicare and my wife isn't, and what's going to happen to her, et cetera. So then Julie can look up the answers and answer on the air. Another way to sort of explain things is to not even explain it yourself at all, link to other resources. The Hill and lots of other news organizations link to the Kaiser Family Foundation web video, which is like a 7-minute cartoon that explains the law. So, and you could even embed that, and then you haven't done the work, but you've put it out there for your readers. Of course, the main thing is features that we can do. We can follow characters. And the characters don't have to be people, but they're often people. They can be companies. They can be the California Endowment's effort. That could be a character. What are they doing and how are they doing it to recruit people to get to sign up? We did a series with NPR called Are You Covered, where we identified 9 different types of people. Then we went and interviewed them. We wrote stories. We did videos. We did slideshows to personalize what was going on with the law. This guy on the right, he was uninsured involuntarily or involuntarily, I don't know the right word, and he actually would go home to his family in Guatemala whenever he needed anything like a knee replacement done. This woman, this was a great story, and this is the most popular one of the series. She was uninsured by choice. She still is, because she says she lives healthy and she doesn't want to buy insurance. And when the penalty kicks in, she'll be okay because she got married to somebody who has insurance. Another way to do things is we've been interviewing key players, and key players can be anybody. It can be, you know, Max Baucus, if you want, who's a senator from Montana who runs one of the efforts on Capitol Hill on the health law, or Julie Appleby just last week interviewed a tax accountant who could explain what the tax issues are on the penalties and buying and getting subsidies. Very interesting. Another way to deal with it is we found that if you compare different counties, especially in like California, you get different stories. You can compare counties, you can compare businesses, you can compare countries, and you have a way to sort of say, here's one place, here's another place, here's another type, and it's effective to people to understand. Another explainer type thing that we've loved, this is fact-checking things. That gets really cool around Election Day. Washington Post started a regular feature on fact-checking lots of things. It often features healthcare, and they have a Pinocchio scale of not true from 0 to 4. So this particular claim was not great for the president, but it wasn't terrible. The other way is opinion. So people write editorials from the editors of the news organization. They solicit commentary. That can be a columnist or it can be a guest commentary. We used to do that with lots of different people, including policy experts who have opinion. And then we solicited some first-person stories. And then finally, we do, and other people do, political cartoons. Our political cartoons on our site are just about health care. And at one point, we commissioned a 4 or 5 page, almost comic strip about this woman's search for health insurance, and it was extremely funny, did very well for us, and she's great. Jen Sorensen is her name, and she just actually won a prize for this, the Robert F. Kennedy Award. So those are a lot of ways that you can get at this story, and I'm very excited about all of them because I think it's, like I said, the gift that keeps on giving. Thank you very much.
Thank you, Peggy. That was wonderful. So we have a bunch of questions here, and I'm just going to pick a selection of them. Sometimes numerous people have the same question, and we've got about 15 minutes for questions. So this one is from Kara Gavin. What role do the panelists see hospitals and physician groups playing in encouraging enrollment? And all 3 panelists are unmuted, so you can all speak. Peggy, do you want to start out answering that?
Oh, well, I think actually Richard Figueroa would be the best.
Richard, do you want to take a chance?
Sure. So we actually think, you know, providers generally are going to be a critical entry point, and providers can be trained as certified enrollment counselors. And so we would, you know, for example, our California Hospital Association has just put out a brand new publication, very, very detailed about all the ways that hospitals will be affected by the ACA and can participate in enrollment and outreach efforts. Covered California is also in the process of having a relatively small grant program compared to the community-based grant program, specifically for provider organizations. So to assist them not only in understanding the Affordable Care Act, but enrolling people when they come through the door. It's kind of, I think, providers are a very critical element to providing kind of a greater push for what we would call a culture of coverage. So there's an expectation when people come in the door that they, unless they're undocumented, that they have either purchased or are maintaining coverage.
Great. I'm going to actually, in the interest of just getting through as many questions as we can, maybe just have one panelists jump in and answer, and then we can, try to get through more questions. This one is from Lana Benton. How is the ACA expected to, quote, capture the homeless? Richard, that might be your question too.
Yeah, I mean, most of the homeless will be eligible for Medicaid, and that is a particular focus of our Medicaid outreach grants here. Again, we're going to have to go through the places that they most obviously frequent, and that'd be like homeless service providers and on the healthcare side, emergency departments. So they're going to be a particular focus. If they're not already on SSI SSP, which gives them Medicaid, they're going to be a particular focus of our Medicaid outreach through the places they're most likely to frequent.
I have a brief thing on that, Michelle. This is Peggy.
Yeah, go for it.
We've done a few stories on what they call frequent flyers, people who practically live in the emergency room, and that can be the homeless. We just did one about somebody who was homeless, and he was living in his car, and he was using the emergency room as a place to sleep. So that's a great story, and and there's a program that can help deal with this, where they're paying for social services for these people, and eventually they'll be signed up in Medicaid expansion states. But even in the meantime, it's a good story because of how they get their health care can be changed by programs that move them around to try to deal with their high emergency room costs.
And if I could add something, this is Michelle Levander. This whole arena of homeless medical care is really doing some very creative things all over the country. And there are some very interesting models for reducing the numbers of frequent flyers, as Peggy mentioned. So I'm going to go into another question. This one's by Virginia Young. In states like Missouri, with a federally run exchange and hands-off state insurance regulators, is there a way to pry loose rate information before the September release?
This is Sarah. I can talk a little bit about that. It's going to be very difficult to get rate information before the insurance department is ready to release it. So I think that's an area where, unfortunately, that really just depends on when Missouri is going to release it. We have seen some federal exchange states release their rate data, Ohio, Virginia, and Indiana, for example. So it is possible they could move forward. One other thing I would encourage you to look at, though, is Enroll America, which is a nonprofit, is doing a lot of outreach in states that are not building their own exchanges. So it's quite possible that Enroll America might be doing some work in Missouri. So they might be one group that could be a good resource.
Yeah, we just covered them canvassing over the weekend in Florida.
So this is a question from Susan Jaffe. She's alluding to something that Richard mentioned, which is the tremendous amount of money that the California Endowment is contributing to support Medicaid enrollment because federal funds don't cover that sufficiently. She wanted to double check on the dollar amount of the endowment's commitment to that and what the expected costs for California imply for other states that don't have foundations, queuing up to help fund expansion.
So it is that particular slide indicated we're putting $150 million in. It's going to be over a several-year period to support Medicaid, Medicaid outreach and enrollment through a variety of different mechanisms. In some cases, when you give the dollars to the state, and it's an approved entity that can give dollars to the state, they're able to match that with federal dollars, and so we have some cases where we expect that those dollars should be matched by the federal government. But as noted earlier, there wasn't like exchange grants for the Medicaid side. We have a number of foundations in other parts of the country that are also actively looking at how they might support or do things kind of alongside their California Health Benefit Exchanges, or in some cases their Medicaid. But it is. We are blessed in California to have a number of foundations, and I'm blessed to have a board that's supportive.
So I'm seeing a couple of questions here about this option by the states on the Medicaid expansion and what that will mean for enrollment and just the entire conundrum for those trying to sign people up. I know, Sarah, you had a slide about that. Did you want to expand on that a little bit?
Sure. I think it's definitely a challenge that the supporters of the Affordable Care Act were not expecting. And to give you a sense of who will qualify for what, um, traditionally the way the Affordable Care Act was written by legislators was that everyone below 133% of the poverty line, about $15,000 for an individual, would qualify for Medicaid. Those above 133% would qualify for tax subsidies to buy private coverage. In the states that are not expanding Medicaid, everyone above the poverty line, and this is a bit confusing, but it is important, everyone above the poverty line, because of the way the law was written, will qualify for tax subsidies. Everyone below the poverty line will essentially be out of luck unless there is some other program or some pre-existing Medicaid coverage. And the big challenge that health law supporters think they see is how they explain to people, you earn too little to qualify for assistance. And they are certainly trying their best to message around it, but I think they do realize that it's a very significant challenge, and I think it'd make for some very interesting stories to even look at two families in your local community, one just above the poverty line and one just below it, and look at the very different experiences they're having with the Affordable Care Act.
That sounds great, Sarah. Thank you. I have a question here from Jeff Hansel. Do you believe large health organizations will suddenly have spare revenue because patients who previously ate up uncompensated care will now in general, that these healthcare facilities will now get paid for the care they provide for a larger proportion of patients?
I can take a shot at that. This is Sarah again. The hospitals I talked to aren't expecting a giant surge in revenue. Essentially, the deal they made when they supported the Affordable Care Act would, as the person posing this question mentioned, they would get more revenue from all these people who were uninsured now having someone to pay for them. At the same time, they accepted a lot of cuts to their Medicare payments. One of the ways that the healthcare law pays for the expansion of insurance is by cutting what we pay hospitals in the Medicare program. So they might come out a little bit ahead, but I don't think they're expecting right now a giant windfall from these new patients.
Here's a question from Andy Davis.
Can I say one thing about that?
Oh, sure,
Peggy,
sure.
If you're expecting doctors or hospitals to ever say, we have a lot of extra money, they will never say that. It's like farmers. So if that's the heart of your story, you've got to find it another way other than them sort of offering up their books to say, look at how well we're doing. Sarah, am I being too cynical?
No, I think that's a great point and a great point of skepticism to have in your reporting on hospitals.
So I have a question from Andy Davis, speaking of skepticism. Once rate information is released, how can we judge if the rates are good or bad?
That is a fantastic question. This is Sarah. I've spent a lot of time covering rates, and it is a landmine and very difficult to cover. I just wrote a blog post, which you can see in my blog, Wonk Blog, at the Washington Post, on how easy it is to spin insurance rates. What I would say, a helpful resource is go to the rate filings themselves. I think it's really easy for state insurance departments to make their rates seem very low or very high, depending on what message they want to send about the Affordable Care Act. So sometimes it really requires actually looking at the documents that insurance companies are filing. And these can be difficult to get, but I do think they're worth looking at. The chart I included in my presentation is a helpful benchmark. It shows the average premiums for a certain type of plan. So that's one way to think about, are these high or low, is comparing them to the averages we're seeing across the country. But I would be very careful in all coverage of rates and, don't necessarily trust what insurance departments are putting out.
This is Richard Figueroa. Just on that point, one other thing I would say is, and it kind of gets to Sarah's point, is you have to be kind of looking at apples to apples. And when you're moving from a marketplace that is where insurers can pick and choose who they want to cover to one where they have to cover everybody and provide a lot more services to them because of essential health benefits, the rate comparisons compared to the existing market, unless you're like in New York, which already has already had community rating and broad benefits, can get very tricky.
I have a question here from Jeff Hansel, and someone else had a similar question, which is, what story ideas do you have about the increase in patient volume and the availability of enough nurses and doctors?
This is Peggy. We've already done some stories on this, as have lots of other people. One of the interesting areas to cover around this is the so-called scope of practice, where there's actually tension between doctors and nurse practitioners about who can do what, because they're talking about turning more and more, and that has indeed happened, to nurse practitioners to do lots of the basic primary care, saving doctors to do other things, which is hopefully they think might make medical care less expensive and also be able to accommodate more people. Doctors aren't happy with this, so there's a good tension story there, but there's also a good volume story there. Also, you might want to check in on nurse graduation rates and placements. There's some good stories there as well. And lots of people are writing reports about this all the time.
This is Michelle Levander. We can continue answering some of these questions, but I did want to be respectful of everyone's time and let you know that our hour has officially ended. And so if you need to go, there's a couple of things I want to share with you. One is that in about an hour, we will be sending you a quick survey asking you what you like about this webinar and what other topics you might be interested in. We urge you to complete it because it really helps us with our work. And also, we have received many questions asking about, will these slides be available? Will this recording be available? And we will have this all on our website, and you'll get that link in an email. Probably will be up by tomorrow. But for right now, we can go back to some questions that are here. If our panelists have a little more time, Peggy, Sarah, and Richard, can you stick around for maybe another 10 minutes and see if we can get through a few more questions?
I can do about 5, Peggy.
Okay.
I'm
so then this one is for Richard from a health reporter named Dana Harpster, who covers Southwest Florida. Where did the figures come from regarding the worst places for health insurance in the U.S.? Naples, Florida is apparently number 5.
So that was a slide that we have been using. If I click on it, that actually came from the Gallup-Healthways Index 2012. So that came from a different publication, Gallup-Healthways Index 2012.
Okay. Here's a question from Jack Urquhart. Senator Ted Cruz and others are speaking of defunding the ACA. How will this affect implementation?
I can take a shot at that. This is Sarah. So one thing to keep in mind is that, defunding the Affordable Care Act isn't something we expect to pass through Congress. And even if the Senate, which is controlled by Democrats right now, did sign off on it, it's very unlikely that the president would sign off on a law that would defund his most major legislative accomplishment. So we generally don't expect the Affordable Care Act to get defunded. What would happen if Republicans do move forward on this, and there really is a split in the party right now about this strategy, is that we could be faced with the administration, the Obama administration, having to decide between whether to sign off on that or whether to allow the federal government to shut down, as it did in 1995 briefly. I think it's still a little bit of a ways off, and there's a lot of divides among the Republican Party about this strategy. And I think, to me, generally, it shows that as implementation goes forward, that politically it's going to be a fight, all the way through, that you're going to see efforts by Republicans to tackle the Affordable Care Act, even at the same time that people are enrolling in the new programs.
Here's a question from Alma Martinez. How do you recommend tackling the issue that states, and Alma writes, thinking California, do not really want to conduct outreach to those folks that already qualify for Medicaid but are not enrolled?
How do we recommend covering it? Is that it?
Yes. So I guess the first part is, assessing whether that's true, and then how would you report on it?
I think Richard can talk about whether that's true.
Do you want to talk about covering it, Peggy, though, or?
I think it is covering it. I think the general tension that will exist in all states when they do outreach for the new population is that the brand new population is 100% federally funded, whereas the existing population falls under whatever the current federal-state ratio is for their existing population. So to the extent that you have the woodwork effect, when you do Medicaid outreach, and the Woodwork effect brings in a lot of people that are currently eligible but not enrolled. Those have a definite state fiscal impact.
And Peggy, do you want to jump in on the coverage approaches?
Yeah. One way to get characters, at least in this, would be to go to a community health center where they will be signing up people, and they always are. But because maybe some more people are showing up, you might be able to capture some of these types of people and then follow their story from there and figure out, okay, Bob Smith showed up at the community center with a hurt foot, and then, or at a hospital emergency room, especially a safety net hospital, and you can take us through the steps of what happens to enroll them at that point, and then keep calling up layers of people, and hopefully you get somebody in state government at some point who could say what happens now to Bob Smith and why and how they feel about it.
Peggy, but this is Michelle here. It seems to me, though, even though this tension exists, as Richard points out, ascertaining whether or not a state is really committed to enrolling the existing population, I mean, would that just depend on looking at the budgetary question of how much they're paying for it, or are there other ways? It seems tricky to find out if it's really happening or not happening in your state.
I think you're going to have to look at the numbers of people who enroll, and I'm not sure who keeps those numbers and what their income is. The CMS might have it, or the Kaiser Commission on Medicaid and the uninsured might have it to see enrollment numbers, but it's certainly going to lag in terms of time. You're not going to be able to get it in real time by any means. It'll be months before you start to see how many more people are in there that and what their income level is.
We have a question from Sophia. I'm sorry, go ahead, Peggy.
No, go ahead.
We have a question from Sophia Resnick. What kind of impact do you anticipate from the growing number of states banning abortion coverage from the plans in their state health exchanges?
Sarah might be able to answer.
Yeah, I can take a stab at this. So I think it definitely points at a trend we've been seeing, which we've seen a number of states ban abortion coverage on their health marketplaces, meaning that if you're a plan that sells on this new marketplace, you cannot provide coverage for abortion services. The data we have right now on how frequently insurance plans cover abortion isn't great. There's a little bit of data from the Guttmacher Institute to suggest that the majority of health insurance plans do cover abortion, although it's one data point, and I think it's a number of years old at this point. So we actually don't have a great baseline to measure from. We don't know how frequently insurance plans cover abortion right now. I think what you can say, and this might be, an interesting story to report out in your state, if your state has passed one of these anti-abortion pieces of legislation, is to look at, either talking to the insurance companies or abortion clinics in your state, whether they're seeing an impact or whether this is changing access. And if they, come January when people are purchasing these new plans, if they're seeing more patients pay out of pocket, for example, for an abortion procedure.
And keep in mind that some abortions are done with pills, or abortion-like things are done with pills. And so that's covered possibly in a different part of health plans as well.
I'm seeing a couple of questions from people asking about how either employers or individuals might make decisions in order to handle this new mandate. So here's one from Karen Michelle. Is there an anticipated increase in married couples filing separate IRS tax returns to qualify for subsidies?
I haven't seen that yet. I know there are, a number of ways you can try and not necessarily game the system, but, put yourself in a better standing with the IRS. I recently spoke to one gentleman, and this interview is up on Wonk's blog from a few months back, who was going to work out his tax refund perfectly. So he didn't want to buy health insurance coverage, and he was going to file his taxes just right, where he would be charged that penalty, but since there's limits on what they can do to recoup the penalty, that he would just get around paying it. But it takes a lot of forethought and planning to do this. There's nothing illegal about, filing separately if, if your priority is getting more tax subsidies although I think because it's a relatively complex thing to pull off, I don't expect, or I haven't seen anyone predicting a wave of these new kinds of insurance or IRS tax filings.
We've noticed we're getting a lot more questions over the transom about it, though.
So this will be the final question. This one's from Lisa Alaferis. In California, will lawfully present immigrants below 138% of poverty be eligible for the Medicaid expansion or other states' Medicaid, or must they buy on the covered California or equivalent exchanges in other states?
The answer is both. So for the people that are, for newly legal immigrants, for newly legalized immigrants who've been here less than 5 years, we have a state-only program where they're covered in Medicaid. Those folks get to stay. New legal immigrants who are here less than 5 years that would normally be state-only are going to be enrolled in the exchange, but with a wraparound benefit package and wraparound cost sharing as if they were still in the Medicaid program. And that will be starting next year. So basically, they're going to be in the exchange, but have a benefit and cost-sharing wraparound as if they were in Medicaid, which means they'll still be paying nothing, little to nothing, and have more benefits than the exchange would have while drawing down the federal dollars.
Well, with this, I want to be respectful of everybody's time. I want to thank, first of all, our three excellent panelists, Sarah Cliff, Richard Figueroa, and Peggy Gershman. I want to thank Jill Braden-Balderas and Annabelle Romero for helping to pull this all together. And I want to thank you, the audience, for participating and for all your great questions. Please remember we'll be sending you a survey in the next hour, and if you can fill it out, that would help us a great deal. And lastly, we will be making this recording available and all the slides. They should be up on our reportingonhealth.org tomorrow. Thank you very much.
Thank you.
Thanks.
Bye.